Good evening. Thank you all for turning out. I have a couple of brief announcements before the speaker. First of all, the Civic Association is looking for some new board members. The problem with the old board members is they're hardworking and they're great, but we've squeezed all the good ideas out of them. You have to get a variety of people with a variety of different interests and backgrounds if you're going to have a variety of programs. If you have an interest in serving on the Civic Association board, or if you know somebody who would be good on the Civic Association board, please get a hold of Alan or I and let us know, and we'll talk to the person and take it from there. Next month, on October 22nd, we're having another program that's only a month apart. The reason we're having it on October 22nd is that we have the Republican and Democratic mayoral candidates who are going to be here to debate. So you wouldn't want to miss that. It is a very great pleasure and privilege to introduce to you Dr. Helen, I'm going to screw this up, Chalfin.
Heather Chalfin.
Dr. Chalfin is a graduate of Johns Hopkins Medical School. She did her surgical residency at Johns Hopkins, and she did a residency at the National Institute of Health, a fellowship. And so without any further ado, Dr. Chalfin.
Yep. Testing. No. Testing. Oh, okay. You just have to hold it very close. Well, thank you so much for that warm welcome. And if we could go to our opening slide. Yeah. Fantastic. And I'll tell you when to advance the slides. I'll say next. So thank you all for coming to our talk today that's going to be focused on cancer excellence and specifically how precision medicine can be used to fight cancer. Next. So who am I? You heard a wonderful introduction. I'm going to just add a little bit more next. So as mentioned, I am a urologic oncology surgeon, and I did my medical school and residency at Johns Hopkins. Next. And I did a Society of Urologic Oncology fellowship at the National Institutes of Health. Next. And my research area of interest or expertise, you could say, is what's called the liquid biopsy in genitourinary cancer. And we're going to get into this a little bit more today. Louder? How's that? Wonderful. Next. So I am now here at Frederick Health, next, where I serve as the medical director for clinical trials, next. I advise our precision medicine department alongside Pat Rice. Next. And I'm so pleased to introduce to you Ingrid Halverson, who's here with me to speak this evening. And Ingrid is phenomenal. So Ingrid is part of the leadership of Frederick Health, where she represents her peers. And she now serves as the manager of clinical trials. Next. So she, by trade, is a medical oncology nurse practitioner. Next. By way of University of Maryland and Johns Hopkins, where she spent a decade at the Sidney Kimmel Cancer Center. And this was a big coup for our research department, which allowed us to greatly expand in the past several years and really allowed for many of the exciting projects that we have going on today. And Ingrid's going to be speaking with me here today to you. Next. So first, we want to talk to you about what is cancer. Cancer comes from what are called mutations in the genes of normal cells in the body. And it's really difficult to target just these bad cells without harming the normal cells that are nearby. And we also know that these cancer cells have the ability to become resistant to many different treatments. Next. So what that means is that screening for cancer is very important so that you can catch it at an early stage, which is a very big challenge. Next. Most cancers happen randomly to a person or from exposures that that person has had from their environment. But rarely we can actually have cancers that are caused by a mutation in a gene that passes through families from parent to child. Next. So what do we do? How does precision medicine allow us to fight cancer? And what does it mean to say that we have cancer precision treatment at Frederick Health? Well, it's a multi-part solution. And what we're going to touch upon today is genetics, research, the patient care team, and also modern technology that fits in the fight against cancer. Next. So starting with genetics. Next. Next. So what we were just talking about is that sometimes there can be a mutation in a gene that passes from parents to children. That is called a germline mutation that somebody is born with. And this is quite rare. And one example of this that you may have heard of before is something called the BRCA genes, which are associated with breast, ovarian, and other cancers. Next. On the other hand, what's much more typical and the most common way that a person gets cancer is you have a normal person born from normal parents and they have some type of event in their lives. And here I've given an example of somebody that perhaps had smoked cigarettes and they get a mutation in their bladder cells that then lead to bladder cancer. This is something that develops during someone's life and it's very common. Next. So what do we do about the cases where somebody might have been born with a mutation in their genes from their parents that's going to cause cancer? And I'm very proud to announce that at Frederick Health, we have screening for this that takes place in the regular clinic for regular patient visits. And you can hit next. So what we found, this is a research study that we published from our clinical trials department with Ingrid, where we looked just at my patients that I saw over 1 year. And of the patients that came to see me in the urology clinic, 1 in 4 actually met our national cancer criteria that they should have a blood test to see if they had one of these mutations. And out of the people that we tested, 1 in 12, which is almost 1 in 10, about 10%, which is what you see across the nation, actually had one of these mutations. Next. So in 1 year, I actually found 6 families in our community, families with tons of members, that carry one of these mutations. And most of these people were coming in to see me for non-cancer related reasons, urinary issues or something like that. Next. So to talk some more about research that we're doing in this area, I wanted to show Miles, that's in the audience here, who wants to be a biochemist there, that this is a photograph that I took while I was at Johns Hopkins of a bladder cancer cell. So you can see the green cell there amongst the background of white blood cells. And this was imaged on the rare site CTC, or circulating tumor cell detection platform. So this is sort of the new wave of research, and we're going to get into it right now. Next. Next. So how do we figure out if you have a cancer? Well, a lot of people have come to see me, unfortunately, have had this biopsy gun interact with their body, and that's becoming now more of an old-fashioned way to find out if someone has cancer. Next. Next. And so what's becoming the new wave through research is something that's called the liquid biopsy, where just like I showed you that cancer cell floating around in the blood, we can actually look for disease markers in someone's blood, urine, or sputum, and we call this the liquid biopsy. Next. And to explain further what that means, here's a diagram of this. And up in the top left, you can see a yellow tumor with lots of cells. And you can see that the cells actually escape and get into the bloodstream with the red blood cells there. And what that means is that when you take a blood sample, you can potentially detect either the circulating tumor cells or the DNA, the cancer mutated DNA from these cells. Next. So what I'm going to talk to you about is that when a person has a liquid biopsy, that offers an opportunity for early detection of cancer. And this is a big area of research in cancer right now. And what's going to happen next is Ingrid is going to explain to you different types of questions that we can address for patients using these liquid biopsies. She's going to walk you through the scenarios and the questions, and then she's going to give you a little snippet of the trials that we have right here at our cancer center in Frederick Health that aim to answer some of these questions. Now, this isn't everything that we have, but just a little snippet. So I'll turn it over to Ingrid.
You encourage questions during the patients after.
Maybe after is good if that works for you guys. Whatever you think. Next.
Okay, so hi everybody. So at a cancer diagnosis, the first question is, how bad is it? So we move on to the types of patients that can be treated with the liquid biopsy. The question can be, who can safely have less treatment? So an example of this would be, a patient that may not need surgery, a patient that may just need radiation. What are things that we can do? What are less things we can do? The next question a liquid biopsy can tell us is who needs more aggressive treatment. Some patients may need more aggressive types of chemotherapy, radiations, or procedures to get their cancer. And then the next question we're answering with research is, which treatment will this cancer respond to?
Next.
And then on top of that, the next question is, after treatment, whose cancer is likely to come back? And that is where the ctDNA really comes into play. Because what we're finding is that ctDNA can detect cancer recurrence 3 months before a CT scan. And that is what clinical research is doing right now, working towards that type of technology.
Next.
In purple here, you can see the studies that we have to sort of answer some of these questions. So who can safely have less treatments? Those are, one trial is through the NIH, which is a surgical sample trial. And then the other two below it are actually de-escalation therapies. So we're looking at giving less toxic chemo to look at better, side effect profiles, quality of life, long-term health impacts. Acento 5 is sort of the opposite. So who needs more treatment for aggressive cancer? So these are actually Acento 5, Offset, Destiny, Adura, and Circulate are actually looking at adding more chemotherapy, more treatment to hopefully improve survivals. And then finally, which treatments do these cancers respond to? So we have, again, with the NIH, and then with a company called Elephas, they're actually looking at technology that lives in the lab, where they can at the bench look and see, is this cancer going to respond to a certain type of treatments? Finally, with the ctDNA, it circulates, and Apollo at the NIH are looking at blood tests to see whose cancer is going to come back before the CT scan.
Next. So thank you, Ingrid. That's a great introduction to something that we call the Frederick Health Biobank. So far, I've told you about national clinical trials that we have open as a site here at Frederick Health. But something else that we've been working on for the past 4 or 5 years and is finally open is called the Frederick Health Biobank. Next. So what's a biobank, first of all? Next. A biobank is when you collect liquid biopsy specimens from patients in order to do this type of precision research. Next. So why do we need to have our own Frederick Health Biobank? So far, we've been collaborating with companies that Ingrid mentioned, like Elephas, that collect their own samples, or the NIH, or there's even a biobank in Frederick called the Precision 4 Medicine Biobank that we have some studies with. So why do we need our own that we have now at Frederick Health? And that's one big answer to that is that means that a community of experts and an oversight committee here at Frederick Health can decide which projects are important, which projects have merit. We're not just sending samples to a company that's going to decide that externally. We, the Frederick Health community, can decide that with our experts. Next. Oh, go back by one. And the other big point that we've known from studying biobanks and also my work at the Johns Hopkins Brady Urological Biobank is that communities who are represented in biobanks are the patients who will benefit the most from the research. If you think about it, and all the studies are done on patient samples where the patients are very different from you, we don't know if the results are going to apply to you. So it's very important to have a diverse group of people and certain communities give their samples so that when we have new technology that's developed based on those samples, we know that it will be applicable to you. So that's another benefit of having our own community biobank. Next. And Ingrid is going to take you through some of the details of our local biobank that she has developed here in Frederick.
So the biobank is something we're incredibly proud of. We have built this from the ground up, and this picture right here is a screenshot of an electronic data capture system called RedCap, and it's through Johns Hopkins. And we are using this data entry to input the information of the patients that we are entering into the biobank. We are also really excited and proud to have this blue machine. It is the Brady label maker, and it provides us with little cryogenic barcoded labels. So when we place our specimens in the freezer, they're barcoded, they're scanned, and they're easily inventoried.
Next. So changing the topic now, when we're thinking about cancer excellence and precision medicine, to the patient care team. Next. The patient care team and patient navigation is essential to have good outcomes when you're trying to do cancer care and precision medicine. And we are so fortunate, as part of our team at the Stockman Cancer Center and at Frederick Health, we have really excellent patient navigators. And who you're seeing up here is PA Taylor Rose, who actually won an award of the most valuable at Frederick Health. And these are a patient's own words where they say, it's hard to find the words to explain how amazing Taylor is. You can call her anytime. She helped us ease the turmoil and stress of communication. She was a glimmer of hope, a beacon in the dim landscape. And so we are bringing this model to Frederick Health to help guide patients through their multidisciplinary cancer care. Next. And here you can see one of my prostate cancer patients as featured on the Frederick Health Community Impact Report to discuss how patient navigation really helped with their journey. Next. So then turning to another very important component of technology. Next. I'm going to take you through certain technologies that we use to fight cancer with precision at Frederick Health. So on the far left, what you can see there is the Da Vinci surgical robot machine that I use to do bladder, kidney, and prostate surgeries on my cancer patients. And we're very fortunate that at Frederick Health, we have multiple Da Vinci robots and we have the top of the line systems. And what this does, it's really not a robot for the scientists in the audience. You know, there's criteria of what you have to do to be able to be a robot. You have to do things all by yourself. But really, it's a power tool that I use to do the surgery. And it gives me 10 times visual magnification. It lets me have 3 hands instead of the 2 that I have. And it can turn its wrists much more than a human wrist can turn in order to do deep surgery down in the pelvis. Next. Next. Good. Okay, so then in the middle, what you're seeing is something that's called the precision point for a special type of prostate biopsy that we're going to dive into. But the preview is that this new type of prostate biopsy is much safer and it's better at detecting cancer. So Ingrid and I ran a clinical trial where we looked at the outcomes at Frederick Health of this newer, safer biopsy method. None of the patients that got the new biopsy method had a sepsis, which is a serious infection that can happen. And 1/3 of our patients had cancers that were found that would have been missed by the other type of old-fashioned prostate biopsy. We'll get into that more next. And then, oh, sorry, I said the word next. Go back. That was just a regular next. Okay, so and then the last thing that you're going to see to the right of the slide is something that we'll talk about, which is blue light technology that helps to detect bladder cancer better. So now I'm going to say next, for real. So let's talk about this new, safer prostate biopsy. Okay, so many of you might be aware of the old-fashioned, or what we call a transrectal, through the rectum prostate biopsy. For this one, the old-fashioned one, the needles of the biopsy actually go through your stool, pardon me, your poop, and then into your body. And so what that does is it causes 2 major problems. One is 1 in 50 men will end up in sepsis in ICU from this biopsy. And also we know that not all prostate cancer is in the back of the prostate. And since they're going through your rectum, they can only reach to the back of the prostate. Especially for Black men, they're likely to have cancer in the front of the prostate that would be missed. So what about this new biopsy? So this is called the transperineal or TP biopsy. And here, the needles actually go through the clean skin. And what that does for us is only 1 in 1,000 patients would get sick from this biopsy. And we can check the front, middle, and back of the prostate. Next. So then the last technology that I want to make you aware of is something that's called CysView, or blue light. And I'm excited to announce that I did the first blue light cakes in Frederick a couple weeks ago, although this is something that I've been using at Johns Hopkins for a decade. So what is this? This is a special molecule that goes into the bladder that gets taken up by bladder cancer cells and lets them show up as pink when you shine a blue light on it. Now, one of the problems with bladder cancer is that most of the tumors look like little broccoli fingers, but sometimes you can have a flat tumor that's very difficult to see. You can see in some of these examples here, you wouldn't see any tumor here in this example, but then you can see spots that are lighting up pink on the blue light. And so that's why it's a valuable tool, that it's fantastic that we now have. And the fact that we have it here at Frederick Health, I think within 50 miles in all of Western Maryland, there's no other site that has this. Next page. So once again, this detects cancer that would otherwise be missed. It's actually recommended in cancer guidelines. And this here is a photo of one of my patients who wanted to use his voice to raise awareness, to bring this technology to Frederick. And he is someone who had to travel all the way to Johns Hopkins in Baltimore to have this done from time to time while I was taking care of him. And he works at Costco. He's very hardworking, and it's very disruptive for him and his family, for him to have to go so far to have his cancer care. And now we can offer that to him here in Frederick. Next. So I'm going to turn it over to Ingrid.
All right. So I know we're going to do questions and answers afterwards, but one thing I wanted to let you guys know is that there's ways to get involved. Something we talked about today interests you or maybe relevant to you or your health. There's some ways to get connected with Frederick Health. So the first one is self-refer to precision medicine. If you have an oncologist at Frederick Health, speak to your oncologist at Frederick Health. We have a website, clinical trial website, and then also clinical trials at Frederick Health is our email address, and it comes directly to me, and I can triage any questions that you may have about our trials or about anything that we talked about tonight.
Next.
And then just lastly, this is sort of the trials that we have available at Frederick Health. So we currently have 23 clinical trials open and accruing to patients in Frederick. We've enrolled in the past 3 years 144 patients to them, and you can sort of see the breakdown by cancer type. We're very heavy on the breast cancer side currently, but as you can see to the pending clinical trials, we're moving into the lung space, and then we're actually moving more into the GU space as well. Just hasn't made this chart yet.
Next.
That's it. Thank you guys so much.
Thank you.
I have a microphone. Let's make sure.
I was saying from the camera.
Yes.
I have a couple of questions. This new type of, I'm trying to have it written on my phone here. Does insurance cover this liquid biopsy?
Great question. Maybe we can possibly turn the projector light off because we're getting a little blinded up here. If that's possible. So that is a difficult question to answer because liquid biopsy is such a vast term. So, for example, we've talked about tonight how sometimes liquid biopsies are part of a clinical trial, in which case there's no cost to a patient. We've also given examples of where regular patients come to my clinic or a clinic at Frederick Health and they're offered a standard of care liquid biopsy that is actually recommended by our national cancer guidelines. And there's different individual ones in different companies, but by far and away, the cost of these have come way down. In many cases, insurance covers these because it's recommended by our national cancer guidelines. And in the event that you get no insurance coverage, usually the amount that you would have to pay is under $300 for these types of tests.
Now, my last question has to do with the types of cancers. You're mostly into bladder and prostate. And this liquid biopsy, does it get all types of cancers? Like it would get pulmonary thyroid cancer?
That's a great question too. So we really have to be detailed about what kind of tests we're talking about. So some of the tests that we've talked about, I'm not out of the camera range. How's this? Further. Good?
This is for the people who can see it tomorrow.
Okay. So, one of the tests that I talked about, which is when we're checking to see if you have a mutation in a gene that passes through families, The one we typically use at Frederick Health is the Ambry Genetics Cancer Next test, which includes 40 genes that are involved in hereditary cancer. So those are all the currently known genes that are involved in hereditary cancer. Another example of a liquid biopsy test that we now have available in our precision medicine department is called the Gallery test, and that's screening to detect cancers. That test is a one of a kind currently on the market, and one of our projects in our biobank is to help Johns Hopkins develop an alternate test, and there's others that are going to be emerging onto the market. But the Grail Gallery test is currently available in our precision medicine department. Right now, it's mainly being offered to patients that we know have these mutations and they're at high risk to personally develop cancer. And there are certain cancer types that are easier to detect the circulating tumor DNA than others. And each individual test that you take is going to have a different sensitivity profile for every single different type of cancer. Hopefully that answered those wonderful questions. Mm-hmm.
I want to thank you for your very enlightening presentation, and it's really reassuring to have your quality of care right here. So
Thank you.
Thank you for being available to us. I'm going to ask the elephant in the room here. How threatened or how affected do you feel you may be by the current Trump administration's attitude towards research and the restrictions in funding? Have you been impacted by that?
We have. So our open trials with NIH have lost funding to the point where they cannot even afford the courier that they typically send to pick up the tumor specimens from our hospital.
I would expect that perhaps something like that. I hope everyone hears that and remembers that when you go to the voting booth.
If you could talk a little bit more about the sensitivity of the tests. For example, after if you get a negative result from the things the Ambry test that's the 40 genes that says you're negative, how accurate is that? I mean, is that you can really take a deep breath and realize you're gonna be okay, or is that just because that's such a small portion of the cancers that people get? Is it very meaningful?
Great question. So that test is fairly accurate in terms of detecting if you have the mutation, if you do, because that test actually also includes RNA and not just DNA, like some other saliva test will. It's a blood test. But to your point, that test is just checking to see if you have the rare. It's not super rare because, like we talked about, of the people that answered the screening test, 1 in 4 met criteria, and then about 1 in 10 did have one of those mutations. So, but it's certainly the much more rare way to get a cancer. But if you're identified as someone that has a concerning personal or family history of cancer, it can help you to answer the question of, should you be worried because your family member has a question, with the caveat that we have not discovered all of the genes and mutations that lead to hereditary cancer. But one of the nice things about the programs is that they provide updates, future updates. When things get reclassified, they provide updates to our department that we can then notify our patients. Mm-hmm.
I think we're all looking forward to a blood test that will detect all cancers. Now, of course, we know that cancers are constantly evolving, but what kind of progress are they making in that area?
Yeah, so it's actually very novel that we're able to offer the Grail test, and it's actually through a charitable donation from the Patty Hurwitz Fund. That there's been some funding set aside for patients that can't otherwise afford that testing. Because breast cancer is one of the ones that the test can detect for as well. But this is something that's actively under development, and we are excited to be a part of this because we have one of our biobank projects is banking specimens from our patients that get that standard of care test And we have collaborators at Johns Hopkins that are developing alternate tests that may well be better. So we and Frederick are actually at the forefront of this because we have a biobank project. Now, one of the things they've shown with the Johns Hopkins test out of Bert Vogelstein's lab is that cancers can be detected 3 years before they're developed. And so it's very interesting to try to understand what's a false positive, what's a false negative. So this is a wonderful investment that Frederick Health has made that we're gonna get back to you on this in like 5 years with what we found here. Mhm.
I think you're saying that you will just have like a blood test for family heritage of cancer. How long would it take to get the results?
The results typically come back in about a month. And that's what we were saying in terms of anybody here can self-refer to the Frederick Health Precision Medicine Department, which is linked through the main Frederick Health website. And you don't need a referral from your doctor. You can come and have an appointment. And if your cancer history of yourself or your family is concerning, you'll be recommended for the test. But also, many people are just interested in having the testing regardless. And people at the NIH and the Human Genome Project that we partner with feel that more testing is better. And so you would then undergo a pre-test counseling appointment to understand what are the pros and the cons of having this test. Just as a quick one-liner, a big pro of the test is you can protect yourself and your family members. If you know you have one of these mutations, you can be watched earlier, take actions early to help prevent a cancer. What are some of the downsides? We talked about costs a little bit. You know, luckily my patients on average paid $0 or $20 for the test. In the worst case, it's usually under $400, $300-400. And the main thing to think about though is that if you're currently shopping for luxury insurances, like more life insurance, more disability insurance, you'd want to finish that shopping first because they could take it into account. But most of my patients are not trying to get more life insurance, you know, at this time, you know. So it usually doesn't end up being a concern for most of my patients. Miles has a question.
Volunteer or shadow program like the SCPS?
We do. There is a wonderful volunteer program at Frederick Health, and I encourage you to get involved.
Are you not still talking about therapy?
You can talk about anything you want. We already had a political discussion. Oh. We got one more question. So he asked about what progress is there in immunotherapy, and I'm going to have Ingrid answer that question. Therapy too.
I mean, there's been a lot of progress with immune therapy. In my time in medical oncology, we started with just 1 or 2 different drugs, and now we're moving into multiple different drugs, and now they're combining different drugs together to get different targets using the immune system. They're also combining immune therapy with chemotherapy to use the immune function and then the cytotoxic action of chemotherapy. So it's come a huge long way.
That's find out answer somewhere in my mind. Would this be a better way to go?
Well, excitingly, nowadays, there's different types of PET scans that are specific to different cancers. For example, for prostate cancer, we have the prostate-specific membrane antigen PET scan. And there are other cancers, like kidney cancer, which in most cases don't even show up on a PET scan. So I don't think that anyone would probably recommend you to randomly have a PET scan But yeah, if you were interested in doing what was the state of the art to see if you currently had a cancer, your best test would be one of these blood tests. And I think it'd be great for you to have a discussion with Pat Rice in precision medicine, because that's her area of expertise, and she could advise you on all of your options. And you see advertised and celebrities and Kim Kardashian get full body scans. You know, that's not recommended by any type of guidelines, but some people do that.
You got it, Sally.
Yes, so we have community radiology, which is partnered with Frederick Health, where patients get PET scans. We also have associations with Charter Radiology for some of our clinical trials. They do some of our imaging. That Ingrid set up that collaboration with them. And there's also the radiology clinic that's down the road as well.
I don't think I may have a mic. I would like to know what your thoughts are on, oops, I got mine. I would like to know what your thoughts are on AI assisted research. I know that one of the things that I have been suggested to do, and I know a lot of people have, are the AI enhanced mammograms. And are we now going into an area of medicine where there is going to be more AI assisted tests coming along?
I would say yes. In fact, there's a new AI assisted test for prostate cancer risk stratification called Artera that we're going to consider starting to use in our prostate multidisciplinary clinic. I think that is going to be part of the new wave of medicine.
Studies to determine how many false positives or extra tests come from the new AI systems. For example, I was told after radiology clinic AI had a high risk for breast cancer, which I had not in the past, and I'm having to do extra tests because of that. And I'm wondering how good that information is to know whether that's a real thing or it's just still in process.
I don't think we really know the answer there, to be honest. I'm not sure. I think that the thing about AI that's sort of tricky is that they're using your data to improve their platform. And so it's constantly improving theoretically. Every platform, every test, that they're all using some different version of AI. And I'm sure there's additional testing that happens as a result of it. And it does put the patient in a weird spot, right? Because you're like, if I don't do those tests, because I don't really understand why, I don't have a family history, and I get cancer, don't blame yourself. So you just want to do it.
And that's what I would agree with Ingrid regarding. But I will say, you know, we're personally involved with the Elephas company that's sort of using AI and image recognition to help identify if you have a patient's tumor, which immunotherapy does it respond to? And it's doing that by taking tumor specimens and actually applying the immunotherapy drug to it in the lab and using that to verify the results. So, and then we also talked about today that some of these liquid biopsies provide results 3 years before someone actually develops a cancer. So, you know, I think it's a combination of all of the above. And then we have a question in the back after this.
Yeah, just curious, these cancer cells are shedding from the cancer in the bloodstream, and that's the premise for a lot of what you talked about tonight. If you're treated for that cancer, I've heard it said that you're not necessarily ever totally bodily free of cancer, that there are always some cells somewhere that are kind of circulating around. Is the premise that treatment today just obliterates all cancer cells within a particular body after treatment? Is that what if you did, in other words, a liquid test on someone 5 years down the road, that would be expected to be totally negative?
Great question. And this is actually my area of research. And so there's two ways that we look at that. One is circulating tumor DNA, which can actually just be shed by the primary tumor and doesn't necessarily mean that there's tumor cells circulating around. And then what's much harder is the detection of the actual cell itself. And so there's things that limit the research in both of those areas. One is, if you're thinking about such low levels that you're trying to detect the cancer DNA among all of the normal DNA in the blood, and then you're sequencing it, and you may have sequencing errors that introduce a mutation. And so there's some very exciting research on that out again, the Bert Vogelstein lab, of new technologies that help to prevent those sequencing errors. But there's going to be a lower limit of detection. It's very hard to detect these things. And then when you think about circulating tumor cells, this technology is in its infancy. So we talk about how these are detected, and the initial research was just by cell size. You saw in that picture that the big cancer cell was a lot bigger than the blue white blood cells, and they used to just size filter them. But we know that some white blood cells are bigger than cancer cells. And then they tried to use cell surface markers, because you shouldn't have skin markers floating around in your blood. And then we found that, hey, actually there are skin markers on some cells floating around in the blood. And then we tried to use all these different markers, and it's very difficult to stain cells with all of them. And then you want to take one of these cells and confirm that it actually is a cancer cell that you've detected. And so they have this robot that has a little ceramic needle that claims to be able to pick up a single cell off the slide, and that it's still partially alive, that you can then sequence it. And then you're trying to do single cell sequencing of a single nucleus. So these are some of the things that are in the way of anyone being able to accurately answer your question that you just asked. Mm-hmm. Mm-hmm.
I have another question. So you find these cells in the test. After you found these cells in the test, two questions. How do you determine what kind of cancer it is and where it actually is in your body?
So again, a lot of these things are still in research. The only cancer that mainly and first is using the circulating tumor cell test, there are others trickling in, but a main one is metastatic prostate cancer. And there's a test called Cell Search, which again is based on sort of the old-fashioned technology. But the test in that case is being used in people that you know have prostate cancer, and you're trying to understand something about it. Or if you're looking for circulating tumor DNA, in some cases, they take the primary tumor that the patient has had biopsied and they sequence it. And they make sure that the same DNA mutations they actually use those DNA mutations to detect the cancer DNA that's floating around.
So if you find it in the blood, then you still have to do the biopsy of the prostate to really find out if it's there.
So in the future, no.
But
All of this is almost, I would say 99% of this is research basis at this time. It's gonna be here very soon, but most of this, so for example, say you did that Grail Gallery test that I was talking about, and it comes back as that something has been detected. At this time, you then embark on the standard of care test to try to find that cancer. And you may not find anything because it can take up to 3 years. Mm-hmm. Mm-hmm.
Is the old PSA test really old?
It's very old, but it's also very important. It's the front line of how we detect prostate cancer. And unfortunately, in Frederick, there's a problem with people not getting PSA screening or not understanding what's an abnormal PSA. Mm-hmm. Because the United States Preventative Task Force issued a bad rating for PSA screening, and they said not to do it to all the primary care doctors. And then they saw that more people died of prostate cancer as a result of that. And so they overturned it. But you have to imagine these primary care doctors, they have to keep up with every single disease and condition. How many of them that heard not to do it then heard, oh, actually you should do it, and it still has a C rating. And they're worried about over treatment and side effects from prostate cancer treatment. But we now know that not everybody that has a high PSA has to have a biopsy. We have a prostate MRI as a screening test. We now know that just because we diagnose a low risk prostate cancer doesn't mean that we have to treat it. We have genomic scores now. We have an active surveillance program. So we've done all these things that mitigate the harms of the screening, and it's been recommended again. But how do you expect a primary care doctor to keep up on every single little thing, especially when you're here in Frederick and you've been a primary care doctor for a billion years?
My problem. That and cancer, really, right?
Mhm.
There'll be cancer of the prostate in every older male, right? To some degree.
1 in 8 men get prostate cancer in the United States.
Oh, you won't die from genetic type.
1 in 8 men get.
You got a chance,
Yeah.
Question right here.
On the topic you just spoke about, does that apply to elderly men also? They used to tell us that after a certain age, you didn't need to get your prostate checked because you were gonna die of something else anyway.
Yeah.
Is there a age
Well,
recommends people not have PSA tested?
what it is that if your PSA has always been normal and then you're over age 70, you do not need to continue screening. But people don't understand that normal means that the number starts with 2, less than 3. And if you take a medicine called finasteride or dutasteride, that's supposed to lower your PSA by half. So you have to double it, at least lower it by half. And if you look at, poor Joe Biden, he has metastatic cancer now. We should have ideally known about that,
Had he not, had he not had PSA test?
Anyone, sorry, oh.
Had he not had PSA test?
He had a PSA test. That information's been released, but we don't know what the value was or what exactly transpired in his care. But regardless of what happened with him as an individual, it certainly brought attention to the importance of prostate cancer screening for everybody.
Thank you.
Mhm.
What age does that start and how long should it happen?
The American Urological Association just updated that the starting age for prostate cancer screening should be age 45, unless there are certain concerns like Black race, certain family history of prostate cancer, or again, genetic predisposition to prostate cancer, in which case the age should be 40. So there's different schools of thought. If the initial test at a very young age is normal, sometimes you can have a little bit of a break, but generally the answer is once a year until age 70, if it's normal at age 70.
New administration, is there any change in PSA tests? Since they seem to be changing everything else.
I haven't noticed any change except for that I think that people are more interested in it now after President Biden's diagnosis. Mhm. Yeah, raise awareness. Question.
So these collection of the 3 check cells, and you are putting in your bank, and say that person was negative, and you don't know anything for 3 years before it happens anymore. Do you have to come back every year or every so often for extra tests? And how does this work as like kind of like a data collection type of test at this point?
Great question. So this test is primarily. Oh, so she was just asking, if people get this test in our Frederick Health Biobank, and we might not see something for 3 years later, how are we following these patients? And so this biobank population in this test is primarily recommended and intended for the people who are followed in our Frederick Health Precision Medicine high risk cancer clinic, which is where we follow and take care of people that have the germline test and you've been found that you have a BRCA mutation. Well, if you'd like to, you can have this Braille Gallery test once a year to see if it detects anything, and you have the option of contributing to our biobank. The biobank specimens are on a research basis. It's an IRB approved protocol where results are not returned to individual patients, but the Braille Gallery test is a standard of care test where you get results right after you do the test and you're followed in this clinic once in a year if you're at high risk to develop cancer.
Oh, we can move over. We keep wandering.
I have another question, and that is, we talked a lot about prostate cancer. And, I have a question about women's health. I don't know if you're able to address it or not. But if, you are a woman, the average age for a Pap test stops at like age 50, 55, and they stop doing them. And then the incidence of uterine cancer is starting to rise. What would you suggest for women who no longer are getting Pap tests because it is not covered and Medicare will not cover them? So what do we do to protect ourselves?
Well, I guess I can tell you from a urologist perspective of what we did to fight against the task force when we had a bad rating is simply education and research. And we developed things to offset the concerns that the public had, which was overtreatment and side effects and wasted money. And someone asked a question earlier about what if you have a test result that's concerning and you actually should have never been concerned about it. And so, we did have these concerns with prostate cancer. And so this is something, of course, that's being addressed by leadership and, people that are being politically active and within, I guess it would be the gynecology, academia and departments. It's a great question. But once again, anybody who is interested to do this type of testing is able to self-refer to precision medicine. It costs a couple $100.
Yeah.
Mhm.
Parts that you can give us so that I could recommend you to somebody or myself.
Yes, she asked about whether we have a card. And so we have, which we're going to hopefully make available to everyone here today, we have a direct email to clinical trials at Frederick Health where it goes directly to Ingrid if you have any questions about being involved in a clinical trial. And then a lot of what I've been talking about today is our precision medicine department at Frederick Health. And if you go to the main Frederick Health website, it's linked directly there to the precision medicine department, and you can even click on it and put in your information and they will give you a phone call. Thank you, everybody. Wonderful question. Great audience.